get through an hour. I want to welcome everybody to Ask the Experts, a conversation hosted by SCAD Alliance. I'm Rebecca Freeman. I'll be moderating and leading our conversation today. I am a board member of SCAD Alliance and two-time SCAD survivor. So in addition to Zoom, we're live streaming on Facebook, and then we're also recording the webinar. So if you're not able to stay for the whole thing, or if you don't catch parts of it, check out our YouTube channel and we'll post it to all the social media sites that we are on as well. So today we are wrapping up the year with a full hour of questions. So if you're new to SCAD Alliance, we are a nonprofit organization founded by survivors in partnership with leading cardiologists and health advocates to advance the science of SCAD. So in addition to our independent multi-center iSCAD registry, one of our main goals is to support patients and families. And so as part of that, we've developed this monthly webinar series, Ask the Experts. We've covered topics including physical activity, mental health, genetics, fibromuscular dysplasia. So be sure to check out those recordings for a deeper dive into those topics. We really hope to be able to offer support and education to survivors and caregivers by engaging in these conversations with experts on SCAD-related topics. You know, one of the really unique and inspiring things about SCAD is this amazing team of clinicians nationwide working in collaboration to support patients, both day-to-day and via the research. So all three of the docs today are PIs, or principal investigators, in the iSCAD registry. And in addition to seeing patients in clinic, the part of the job that patients are most familiar with, they're also leaders in SCAD research, so ensuring that we know more each year. So I want to introduce our three doctors today. We have Dr. Sahar Naderi, who is the Director of Women's Heart Health at Kaiser Permanente in San Francisco. Dr. Naderi is very involved with SCAD Alliance as a scientific advisor, the iSCAD Registry Steering Committee member, and the PI for the Kaiser San Francisco site. And in addition to SCAD, Dr. Naderi also focuses on other aortic and genetic diseases like Marfan syndrome. So welcome. We also have moving east, we have from Kansas City, St. Luke's Hospital, Dr. Anna Grodzinsky. Dr. Grodzinsky is the PI for St. Luke's iSCAD site, and she has a special interest in women's cardiovascular disease, pregnancy, and of course, SCAD. So welcome. And we're spanning the whole country today, both coasts. So coming to East Coast in Atlanta, Dr. Bryan Wells from Emory University. Dr. Wells is the PI for the Emory iSCAD site. And in addition to SCAD, Dr. Wells studies other vascular and aortic diseases with a special interest in fibromuscular dysplasia. Last spring, some of you in the Georgia area might have been able to attend the combined SCAD and FMD symposium to support patients and caregivers. So welcome to all three of you. Like I said, so today we really wanted to end the year by wrapping up with lots of questions. Each webinar, we've had patients submit questions. Some of these we've had in advance, some of these are questions that we've had all throughout the year that have been over and over common questions, common things that these doctors hear, and others are more specific questions. So unfortunately, due to sheer volume, we're not going to take live questions today, but please reach out if we don't get to something that you have a question about. So I have grouped these into topics, so we're not all over the place. And want to start with Dr. Wells and some day-to-day things about SCAD. So one question that people ask often is SCAD considered heart disease? You know, we go to the dentist and, you know, are trying to fill out this form, yes or no. People think, okay, but my heart's not diseased, yet I've had this heart attack. You can talk to us a little bit about that.
Yes, that's a good question. And thanks for asking. And thanks again for having me on this webinar. But I think SCAD is a type of heart disease, and there's a whole spectrum. It's not heart disease in the traditional sense when we think about heart attacks that are caused by other more common risk factors such as diabetes and cholesterol and smoking and so forth. But SCAD, when it does occur, can cause a heart attack, and it can cause injury and damage to the heart muscle. It can cause the chest pain. It can cause heart dysfunction and valvular dysfunction. So in a general broad sense, it is heart disease, but not in the traditional way that we think it in terms of some of the other risk factors that you talk about.
Awesome. So we should definitely check yes on that form, just to give other providers a sense of what's going on.
Yes.
You know, in terms of activity, one thing a lot of people are trying to figure out is, how much is too much? How do we gauge what is an appropriate level of activity after SCAD? I know that's different for each patient, but kind of what are some general rules to live by that you recommend?
So there's a real spectrum for that as well, as far as activity level. And that's really, really important because a lot of this, when a SCAD event occurs, this is usually in otherwise young and healthy woman most commonly. So the goal isn't just protecting the heart and surviving, but protecting that quality of life and doing the activities you want to do. And that's very, very important and meaningful. But where do you start? Oftentimes after a SCAD event, we would recommend cardiac rehab to kind of standardize that process and make it a little more formal and structured. And the goals with cardiac rehab or any exercise program after a cardiac event are driven by heart rate and your exertional status or workload. So we start with heart rate goals, and oftentimes it'll be less than 70% of your max heart rate when you're doing something like walking or getting to a jog or run. And again, that's not the same for everybody because they probably have different levels of conditioning before an event, but that's a good rule of thumb. And then you can set goals and build from there. And then you can imagine every activity under the sun, people have questions about what's safe and appropriate to do. But again, and it's not one size fits all, but there are some general guidelines and restrictions about that as far as heart rate and the intensity of the exercise and heavy lifting and other things in terms of, could it be something like a competitive sport or something high intensity that involves contact, like a contact sport, and acceleration, deceleration type of things that we might try to avoid. So there's a huge spectrum there, but one of the take-home points and messages is it doesn't have to be one size fits all, and it's not to be too restrictive on your quality of life. But starting with that heart rate goal is a good rule of thumb.
Awesome. Are there specific exercises that you generally recommend or that people do or avoid? Yeah, again, I understand it's individualized, but are there some that you're like never or
after a SCAD event, what we would encourage is starting with walking and then and increasing that workload, like I mentioned. So walking, then jogging and running. Moderate intensity aerobic exercise is probably the most appropriate answer, and that could be walking, jogging. It could be an exercise bike. It could be something along those lines, and that could be indoors or outdoors. The activities that we try to avoid are the high intensity exercises. So sprinting, competitive sports where you're going to get that heart rate up really, really high, CrossFit, again, heavy lifting where approximately over 30 pounds of heavy lifting could be too much of a strain on the chest wall and the heart muscle. So those are some general restrictions. And then, as you know, that SCAD's a systemic process. So it can involve the other arteries as well, especially if you have FMD associated with it. So we're worried about other arteries, in particular the neck arteries. So things that could damage or injure other arteries, like isometric exercises, roller coasters would be some other ones that we try to avoid.
And when you mention isometric exercises, what are some examples of those?
Push-ups, pull-ups, things like that.
Awesome. No, sounds good. And what about heart rate, I guess, spikes? Or if some people have mentioned, even walking the dog, like sometimes they feel like their heart rate goes up. Is that okay? Or does it kind of depend where it's at?
So that's another good question, is we don't want to get too fixated on the heart rate. Then again, it's going to limit our activities and make us anxious, but using that as a goal and a target for our exercise is good. And keeping a diary is appropriate, and that's important to do. There, with a lot of the heart monitors we have now, like Fitbits and Garmin's and things, that's easy to do, but can drive you crazy if you do it too much.
Absolutely.
So I would say yes, it's important to do, but early after a SCAD event, you may be deconditioned from being in the hospital, not exerting yourself for a number of days. So you may think just simply by walking up the stairs or walking up a hill or across your driveway, your heart rate jumps up. That's probably normal or might be expected early on. But as your conditioning improves, that I would hope that would smooth out.
Awesome. What about some other day-to-day things? A lot of times people ask, is it safe to fly? Fly in airplanes. Not necessarily right now in COVID, but in general post-SCAD.
Good point. So in general, it's safe to fly. After any type of cardiac event or heart attack, it probably depends on the severity of the event, and maybe if you got a stent or had bypass surgery or something more serious like that. After a relatively smaller or minor event, hospitalization from a SCAD, you may be able to fly in 1 or 2 weeks, for example. But something that involved injury to the heart, stenting, something like that, you may be waiting more weeks, closer to 1 to 2 months. So there's a little bit of a spectrum there as well.
That makes sense. What about things like coughing? Some people have asked, can coughing fits? Can that cause, a SCAD event? Can that cause a tear?
Any type of Valsalva maneuver or bearing down type of movement can do that. So that would include coughing, sneezing, holding your breath. Again, getting back to those isometric exercises where you may be bearing down and holding your breath. But we have seen rare instances where something as simple as a cough or a sneeze could trigger dissection. That would be exceedingly rare, but it's possible. And one take-home point for that is if you are having extreme coughing, or more commonly perhaps throwing up or sneezing, where that may be even a little more forceful, trying to suppress that a little bit would be appropriate, because that could injure something like a heart artery or neck artery. That's fairly rare, but we have seen that in some instances.
Okay. And 2 more before I jump over to next topic. But what we have people ask about caffeine and alcohol in moderation. Are those 2 safe post-SCAD?
Yes, in moderation. So you don't have to quit either. 1 to 2 cups or servings of both per day is safe. And another precaution would be avoiding something that could be considered a stimulant. So if you had excessive servings of caffeine, like Red Bull or a lot of coffee, that would be something to avoid. But that also includes some other stimulants, like over the counter, such as Sudafed and other medications like that could spike the blood pressure. But the things you mentioned, alcohol and caffeine specifically, in moderation is okay.
Excellent. I think that's good news for a lot of people. I want to shift over to Dr. Grodzinsky and talk about some medications. There's a lot of different medications that people may be prescribed post-SCAD, depending on what their event was and what their baseline medical status is. But can you talk a little bit about how do some of those typical medications work, and why would they be important? Things like blood thinners and beta blockers.
Absolutely. So thank you again for including me. I think that there's quite a bit of variability in the prescription of blood thinners. Certainly if a patient's SCAD event prompted a stent, then that's sort of a non-negotiable, in that blood thinners act to prevent thrombus or clot in the early period forming within that stent, and perhaps, depending on the size and location of the stent, narrowing over time. So that's a bit dependent on the cardiologist and the features of the stent. In the absence of a stent, blood thinner prescription is variable. And so I'll just pull up, sometimes a picture says 1,000 words. And so I'll just pull up the image here of how platelet medications, or blood thinners as they're commonly known, function. They really block the pathways, the common pathway of which is really to activate the platelets, or the little soldiers that promote clotting in the blood vessel. And so a lot of the agents really function to block the pathways leading to that. And then as it relates to beta blockers, which are commonly prescribed if the blood pressure allows, beta blockers really work to kind of suppress the stress response and heart rate, to relax the heart, to relax the blood vessels during the relaxation stage of the heart cycle. And are commonly prescribed after a SCAD event, shown to reduce the likelihood of SCAD recurrence over time. And for our patients who do have heart muscle changes or a decrease in the pump of the heart strength after a SCAD event, certainly would be indicated to try to augment and improve that heart pump function over time.
Okay, excellent. That makes a lot of sense, especially with the reducing the risk of a recurrence. How long can patients expect to be on a medication like that, on beta blockers?
So as it relates to the blood thinners, highly variable. Sometimes we have seen, because SCAD is considered more of a bleeding, bruising event as compared with a clotting event necessarily. Sometimes aspirin is prescribed alone out to the 6-month mark. Sometimes aspirin is prescribed in combination with sort of a super aspirin for 12 months or so post-event. Probably 1 year is the longest that we think about using those medications. Following a SCAD event, beta blockers are used consistently out to a year. I don't know, and the other panelists may help for documentation or studies supporting much benefit past the 1 year post-event mark. Certainly there's a caveat that if the heart pump function remains low, that beta blockers would remain indicated.
That makes sense. A patient had asked, and I think you may touch on this, but with blood thinner specifically, a patient had asked, if my initial STEMI was not related to a thrombolytic event, why would I be on a blood pressure, or why would I be on a blood thinner?
Sure. So, again, with the stent, that blood thinner will lower the risk of clot forming within the stent. And for some patients, depending on the location and the size of the stent, may lower the risk of re-narrowing over time. In the absence of a stent being felt to be the best treated for a SCAD event, I don't think that we have great evidence to support particularly dual platelet or an aspirin plus a super aspirin combination following a SCAD event, even in the setting of a STEMI, unless, again, a stent is placed.
Right.
A lot of variability, I think, in those prescriptions.
Right, absolutely. What are other medications? Are there vitamin supplements that are typically prescribed or that you recommend, or not particularly?
So I don't know that that's well studied. There have been supplements, for example, in the perimenopausal period that have been linked to SCAD events, exogenous hormones that have been linked to SCAD events in case reports and the like. Unfortunately, we don't have a lot of information about supplements and vitamins aside from those indicated for normal wellness in women, like calcium and vitamin D supplementation in the appropriate settings. So as it relates to vitamins and supplements, not a ton of data outside of sort of usual care.
Makes sense. And speaking of hormones, a patient has asked, is SCAD related to hormones? What do we know about that link?
Probably. So we know that the distribution of when SCAD events occur in a woman's life are what we call kind of bimodal. So often there are sort of spikes in these events in the peri-pregnancy and perimenopausal time periods in a woman's life, though certainly not always. And certainly there are other triggers. And I think the cause of SCAD, most would agree, is what we call multifactorial, in that there are probably genetic predispositions to this condition linked with an environmental trigger or a psychological or a physical trigger or stressor. But the vasa vasorum, which are the tiny blood vessels that supply our heart blood vessels, actually have estrogen and progestin receptors on them. So it's felt that maybe the spikes or fluctuations in hormones cause some disruption in those teeny tiny blood vessels, and that can kind of prompt a bruise to form in the coronary artery.
Mm-hmm. Given that information, is it okay for patients who have had a SCAD to take hormones, either for contraception or thinking treatment in menopausal years?
So that's a great question. Unopposed estrogen is probably not okay. Again, we lack long-term data, but unopposed estrogen is probably not okay. If contraception is indicated, then sort of lowest available dose of IUDs are what has been sort of okayed so far.
Right. And I'm sure it's, again, multifactorial, just because unplanned pregnancy also is not beneficial.
Right.
What about topical estrogen?
So systemic absorption of topical estrogen can be substantial. And so unopposed topical estrogen is not something that I would recommend, but certainly welcome the input of Drs. Naderi and Wells there as well.
Agreed.
Yeah, but I do think, all of these recommendations are general recommendations. And at the end of the day, you have to balance the quality of life issues with the risks, and talk to your doctor. So we all have variations in how we prescribe medications and what our recommendations are. I don't think that necessarily means that one physician's right and another's not. I keep all my patients on long-standing beta blockers. So if any of you out there are my patients, you're probably on a beta blocker well beyond a year, based on some data that suggests perhaps that decreases your risk of recurrence. But again, part of the reason we're also heavily trying to recruit patients into studies is so that we have better answers to these questions, because there's a lot of unknown at this point.
Yes, definitely agree.
Makes a lot of sense. What about jumping away from medications a little bit, but staying within reproductive health, pregnancy? Can patients get pregnant after SCAD, if their event was SCAD pregnancy related or not?
It's a loaded question. Sometimes doctors recommend against pregnancy sort of altogether, but the fact of the matter is that that recommendation or that sense really comes from a small number of patients who had documented pregnancies after a SCAD event that was not initially linked to pregnancy. And during which time some of the patients were not aware that they had had a SCAD event. They had been diagnosed with other conditions leading to their heart attacks. Of 7 patients, 6 did okay and 1 did poorly. And so we're cautious. We're always very cautious with those recommendations. But like Dr. Naderi mentioned, if pregnancy is contemplated, then absolutely a preconception conversation should be had with your cardiologist, with the maternal fetal medicine specialist who can talk about that risk sort of moving forward.
Absolutely makes sense. I want to move over to Dr. Naderi with some heritability and kind of inheritance questions that a lot of people have. And similar to that pregnancy question, some people have said, if I had a SCAD postpartum, is my sister at risk? Is my daughter at risk? What do we know about inheritance in SCAD?
So that's also a little bit of a difficult question. So I'll try to tease it out. In general, I think most of us who see a lot of SCAD patients think, like Dr. Grodzinsky said, that it's multifactorial, meaning there's probably a lot of environmental aspects involved, as well as various genes involved in resulting SCAD. And so for that reason, at least as of 2020, we haven't identified a so-called gene for SCAD. And so there's really nothing we can test for, just as the condition sounds, it's spontaneous. So there's no imaging we can do, no assessment we can do to predict risk of first-degree family members. So as a general rule, we don't screen. Now, the reason it's a little bit of a loaded question, and Dr. Wells can bounce off of this and we can see what he thinks, I think from in the FMD world, there is some thought that there might be some genes out there, although we haven't really solidified the answers to that either. So down the road, there may be some more implications for screening from an FMD standpoint. But if we're talking about kind of just SCAD in general and taking the FMD aside, there's really no way to screen. And I usually tell my concerned patients, you know, can my daughter get pregnant? And those kinds of things that, you know, healthy lifestyle, stress reduction, all of the things that we recommend is really what your first degree family members should focus on. And there's no screening that we would do. I guess the other caveat to that is if somehow your SCAD is associated with a connective tissue condition like Marfan syndrome, Loeys-Dietz, vascular EDS, which we believe is actually a very small proportion of our SCAD patients, then of course there is screening that should be involved for your first degree family members in that respect. So it's a little bit of a convoluted question, but I'd say in general, there's no screening for first degree family members that we do. And Dr. Wells can speak more to kind of the genetics of FMD and what his thoughts are in that regard.
Sure. I think that's important. That's when you have a patient who presents with SCAD is looking for the etiology. We believe now that the most common underlying arteriopathy is fibromuscular dysplasia. It's anywhere from 30 to 80%, but probably at least half of the time contributing to SCAD from what we know, but also looking at things closely and taking a detailed family history to make sure this isn't something else genetic, like a vascular Ehlers-Danlos Marfan situation where the management and the screening would certainly change. So looking for the etiology, and it could be another etiology such as pregnancy or trauma, connective tissue disease, et cetera. And from a FMD perspective, there is a genetic signal there. We do not know of a specific gene that contributes to FMG. It's not the type of genetic association where if your parents have it, you're going to have it, or there's a 50% chance you're going to have it. We don't know it to that detail yet, but there are some genes that we've looked at that we know are associated with FMD and with arterial dissections. We discovered one recently called factor with the pH factor 1 gene, and there's some other pathways that are involved as well. From the US registry for FMD, we think at least 7 or 8% of patients with FMD have a familial type, meaning they have at least a first degree relative with FMD. And what I tell patients who have FMD or suspected FMD, that you're right, we don't do screening for all comers in general for first degree relatives, for example, but I have a low threshold to check family members, particularly female and young female, if they have some of these common signs or symptoms like headaches or pulsatile tinnitus or hypertension at a young age or some other unusual pain, something suggestive of an arteriopathy. I have a lower threshold to evaluate in those situations. That's what I tell my patients.
That makes a lot of sense. And it kind of, another kind of bouncing off that question, that could be for either one of you. It sounds like for patients, we're not pan screening every single person for these genetic, connective tissue disorders or FMD, but who should we be having that conversation with? Who gets screened and why, what triggers screening, and who should be having that conversation, making that decision?
Yeah, that's a really good question. So I think a lot of us who see SCAD also do a lot of connective tissue work. So sometimes that's nice because your cardiologist is in tune with those other diagnoses as well. And so they kind of know what to look out for and what's a warning signal. Again, like Dr. Wells said, I think a really thorough personal and family history of physical exam features, prior complications during surgeries or pregnancies or something in the family that suggested a vascular condition. You can gather all of that information about your family and yourself, even if you're not sure how it's relevant, and bring it to your doctors, even if they're not experts in connective tissue conditions. And if there's enough kind of pieces of the puzzle that suggest there might be a genetic predisposition to a vascular condition, then they can either refer you to a cardiovascular geneticist who can look into it further, or if they're expert in it, can go ahead and send the genetic testing. I think one thing to keep in mind is that you know, a lot of patients ask me, because 23andMe, I'm in San Francisco, so, you know, everyone's like, please pan test me for every genetic mutation that could be out there. And these tests are so readily available just on Amazon that it's like, well, what's the downside of just doing genetic testing on me? Why are you being resistant? And the reality is that I always tell patients there's three possibilities. So one is that we get a hit, meaning we find a mutation that is disease causing. And in some ways, that's the easy one. The other two possibilities is that everything comes out normal. And when that happens, it doesn't necessarily mean that everything's normal. It just means that whatever's going on in you has not been identified in another family in the world. And so normal doesn't necessarily mean there's no issues. The third possibility, which is the one we really worry about, is these variants of unclear significance. And it's exactly what it sounds. You have this variant, this variation from what the human genome usually suggests, but nobody knows if it's actually disease causing or not. And so what happens is it, in a lot of instances, causes grave anxiety for the patient, and also brings up the question of, well, should my family members get tested? Well, we don't even know what it means. So if we start testing your family members, then they're also anxious about some unclear diagnosis. So we try to be really thoughtful about who we genetic test so that the results don't cause more anxiety than good. So I just want to encourage people out there, if you're like, well, what is the reasoning behind the resistance to genetic testing? It's not perfect, and it can cause a lot of uncertainty. So we try to focus it on the patients that really have some alarm bells going off for some sort of genetic predisposition.
That makes sense. What about with related to other conditions? Is there any relation that we know of between SCAD and things like autoimmune disease, lupus, sarcoidosis, some of these? Do we know?
So the answer is yes, definitely. I would say historically, most of us used to test for like a bunch of autoimmune conditions off the bat. And then probably in the last 10 years have realized that we're sending all this testing and it's either coming back negative or it might come back positive, but you don't have any of the clinical criteria that you need to meet for lupus or rheumatoid arthritis. So again, it brings up all this uncertainty. So I've really changed my practice to just testing people who meet clinical criteria or suspicion for these conditions, as opposed to pan testing everybody. The Mayo group actually just came out with a paper maybe last month showing that it's a very small minority of our SCAD patients who have autoimmune conditions. I'd say my experience, the thyroid issues are probably the most prominent. So I do kind of pan test everyone for their thyroid, but we don't start looking for sarcoid or rheumatoid arthritis or lupus or any of these other conditions unless, again, you have other clinical features that would suggest them. Very similar to genetic testing.
That makes sense. Kind of asking that question, what are you going to do with this information?
Right.
And the other question with kind of that heritability inheritance question is if family members have other cardiac things, so hypertension, more traditional heart attacks, is that related to SCAD in any way? Does that change the, I guess, risk of recurrence, or does that change prognosis or how things go? Or
yeah, I mean, I think when you think about it, the answer should be no, but we all have patients with SCAD who have strong family histories of atherosclerotic coronary disease. So it certainly gives us all pause. Sometimes makes you question the diagnosis and you're like, am I missing plaque here? But I'd say we don't really know. It's very unclear. It is always interesting when you have a SCAD patient who's like, my dad had a heart attack at 50. It does give you pause, but I don't think we really understand the correlations, partially because we don't fully understand what causes SCAD in the first place. So I think until we kind of elucidate what the etiology or the cause of this condition is, or the causes of this condition, it's kind of hard to know how that links in with your family history. But I'd say I have a lot of patients who say, my grandpa had AFib. AFib is like a pandemic, like every 70, 80, 90-year-old, I hope none of us on this call seems to have AFib in this world. So I think there's kind of a difference between the cardiovascular conditions that happen just, I don't want to say as a result of aging, but are really as a result of aging in a lot of ways, and the conditions in your family members that seem to be happening at an early age, like male first degree relatives under 55 and female relatives under 65, kind of a separate way of looking at those things.
Makes sense. And part of why I hesitate with that question too is because there are, things like hypertension and AFib, could it be related because they're just common diagnoses?
That's exactly right. I mean, they're so prevalent that it's hard to know what the link is. Now, I think historically we used to say that our SCAD patients had less common cardiovascular risk factors than those who have plaque-related heart disease. And I think that's still true, but I do think we probably were underrepresenting the amount of patients who have high cholesterol and high blood pressure. And we don't have proof for that yet, but I think as we gather more data on our patients, we'll see that, it's not as uncommon as we thought to have, obesity, high blood pressure, pre-diabetes, diabetes, and hyperlipidemia in our cohorts as well.
That makes sense. I want to go to some seasonal questions, just as we are, the reality is this is December of 2020, we're hitting flu season and COVID and all of these things. And this could be really any of the three of you. There is some emerging data we're starting to see about longer term effects of COVID and effects on the vasculature and the heart. What does it mean for SCAD patients?
I can take this one predominantly because there's not a lot that we know about that. So while it's true that there are cardiovascular complications of COVID, among those AFib, myocarditis, inflammation of the heart or inflammation of the heart sac, and stress, related weakness of the heart, because we know that SCAD can sometimes be triggered by respiratory infections or psychological or physical stressors, it would make sense that COVID remains sort of a potential trigger for SCAD, but certainly no causation. We don't have studies documenting the long-term effects of COVID on the cardiovascular system for our patients who have experienced a SCAD event in the past. But it stands to reason that all of our normal mitigation and CDC recommendations apply to our patients who have had a SCAD event. And so we certainly do preach about that.
And it looks like, I know FDA is meeting to discuss this upcoming vaccine. Anything specific that SCAD patients should know about getting a COVID vaccine once that is available?
I don't think so. I don't think there's any precautions you would take beyond what the CDC is recommending for the general public. And as the risk for acquiring a COVID and contracting a COVID infection is probably no different than the general population if you're a SCAD patient. So that should be reassuring to our knowledge. And all the general precautions we should, again, emphasize, which are hand washing, mask wearing, social distancing, being safe with large gatherings, particularly over the holidays. And when the time comes, hopefully sooner rather than later, we'll be prepared to distribute the vaccine in an appropriate way. And there are no significant known adverse risks to the vaccine that would affect a SCAD patient.
Excellent. So we'll all continue to follow CDC guidelines on that. Another thing that I'm guessing you're going to tell us to follow CDC guidelines, flu vaccines, specific, yes, okay. SCAD patients recommend flu vaccines. Any specific things people should look out for, or just do it?
No, I just want to say, I think a lot of my patients are saying, I don't want to go into a public place to get my flu shot. I really think we truly all feel that it's much safer for you to get the flu vaccine than to avoid going into a public space to get it. The other thing I think we're not doing a good job of communicating is that we all do truly feel the hospital is safe. It's just, why come in if you don't need to, right? But the hospital is definitely safer than the grocery store. I feel confident about that. When I walk through my hospital doors, I'm much less anxious than when I walk into the grocery store. So I think we're trying to communicate, yes, limit getting medical attention if you don't think it's urgent. But that doesn't mean we want you to delay care because we're taking our precautions. I mean, none of us have a mask on because we're all hiding, holed up in our offices. But, here in San Francisco, we're like shielded. I look like I'm like outer space woman. You can barely see me and it's like all fogged up because I can't. Anyway, so we're doing our best to protect you. So I think do the things you need to do to take care of your health. Don't avoid the hospital because of fear.
Sounds good. I know in our community, we have even more drive-up clinics this year too for flu vaccines, drive through, not even just stick your arm out the window.
A lot of outdoor tents, a lot of ways to not feel like you have to go into buildings. So do your research, find a place you're comfortable with.
For us, our local health department's been putting that out both on Facebook and in the newspapers and those things too.
Very important.
Is there something you wanted to add, Dr. Wells? Or no?
No, agree with everything that's been said.
Awesome. Sounds good.
I wanted to touch on one thing in case we didn't get to it.
Yes, please.
Rebecca, the one thing that I thought of when we were discussing the screening that has probably been emphasized more than once on these SCAD webinars is when we talk about screening for the etiology of SCAD is the underlying arteriopathy is why we do recommend either a CT angiogram or an MR angiogram of the brain to pelvis. So that's part of the evaluation that is appropriate beyond the thorough personal and family history that Dr. Naderi was recommending. So we know that the prevalence of fibromuscular dysplasia in SCAD patients is quite high. And for that reason, in all SCAD patients, we recommend a PAN scan or a CAT scan or MRI from brain to pelvis. And the reason for that is twofold. One is to perhaps make the diagnosis of fibromuscular dysplasia, which is the most common underlying arteriopathy associated with SCAD. And two is there's a significant chance that we might find an occult or incidental aneurysm or dissection in another vascular bed that may need to be monitored. So just wanted to make that point. And I thought of that while we were talking about screening and evaluation, but that is one important, and again, this is a lot of these points they're data-free zones, meaning a lot of this is expert consensus and anecdotal experience, but that's one thing that we feel strongly about due to the high prevalence of FMD in SCAD.
Wonderful. Thank you very much for adding that in. I know that comes up a lot is good at that, what happens right after SCAD, is what do I need to be screened for? What do I need to do? Thank you. Onto mental health. We did have, just so people know, we did have a whole webinar, this is June, so please check that out for a deep dive. But it's a lot to handle, right? We talked about SCAD being, a lot of the typical patients being younger, healthier, less expected to have cardiac events. Can you talk, Dr. Naderi, do you have a slide on that? On, what can people do? What do you recommend for people to reduce stress, to manage that mental load?
So one thing I always tell my patients is to be kind to yourself. So especially in the few months after a diagnosis, it's really tough. There's probably a fair amount of adjustment disorder and PTSD and a whole host of other things. And I think one thing is, we tell our patients that stress is a big part of SCAD and SCAD recurrence. And then that probably stresses our patients out more because they're like, oh my God, I'm stressed. And then it snowballs. So be kind to yourself, be patient with yourself. Check in with yourself, make sure you're making progress. I think that's what we want to see. If you're just kind of still paralyzed by fear 6 months later, you need to start reaching out to your docs to get more intensive resources. So, it's a healing process. I think if you know, it's easier for me to say because I'm the physician and not the survivor, but I'd say most of the patients feel like 6 months to a year is kind of how much you need to start feeling like you trust your new body again. So I just wanted to start out with that. And then, you know, I'm sitting in my office. I have like a stress ball that I squeeze when I'm having, and I have like essential oils that I sniff. So, you know, you can do stuff like that. Treat yourself for Christmas. But let me pull up these slides and see. Just a quick.
Excellent. And while you're getting that,
I have Snickers bars, so
there you go. Yeah, whatever works for folks to. I don't know why. Oh,
but I think that brings up a lot of it while you're pulling that up, you know, the different ways to do that. Can medications be part of, you know, are patients post-SCAD able to take things like SSRIs, or is there any contraindication to?
I mean, from my standpoint, so I'm a big fan of making sure that you're getting intensive psychotherapy at the same time that you're considering pharmacologics. So, you know, I'm in San Francisco, so nobody likes to take pharmacologics here. It kind of, it's just something that seems very taboo here, you know, for better or for worse, but I've seen it result in some miraculous improvement in people's mental well-being. So I really don't think people out there should dismiss the pharmacologics. I think you should keep an open mind. We certainly don't push them, but you should keep an open mind. But I also think getting plugged in with intensive therapy is really, really important as well. And part of that, so what often happens is you feel like you're coping really well. You feel like you're doing great. You don't feel like you need resources. And then something happens and then you're scrambling to get plugged in with someone that you think is a good fit. So I encourage kind of uniformly all of my SCAD patients and any of you out there, get a therapist you like. One size does not fit all. It's kind of like your doctors. You may not like one, but need to move on to the next to find someone who suits you. So I think everyone could benefit from therapy because it's much better to not try to rush to get plugged in after the fact, but already to have somebody. And you'll sometimes discover there are things you can do to help kind of improve your mental wellness that maybe you didn't recognize before the diagnosis. So those are all really important things. But again, I think I can't stress enough to not feel like the pharmacologics are just, you know, not something that at least you should keep an open mind and consider. And remember, you can always stop them. It's not like, you know, you're stuck with it forever. And then Rebecca, can you see my slides?
Yes, I can. It looks great.
So just a few things. So the SCAD Alliance webinar on the psychological health and PTSD that Rebecca mentioned is on the SCAD Alliance YouTube and Facebook pages. So check that out. I thought it was a really kind of beautiful outline of some things you can do to help in this arena. On the SCAD Alliance page, there's also a fact sheet and breathing exercises at the bottom of that link by Dr. Sumner, one of our really amazing psychiatrists who helps with the SCAD Alliance. So perhaps we can post that somewhere on the Facebook page so that people have a readily accessible link. We're really excited that a bunch of people have contributed to a SCAD Warrior app. So Tina Pittman Wagers, who's over in Colorado, who's a SCAD survivor and a psychologist, has really spearheaded this. So that's officially live now. So please check it out. I think it has a lot of great resources with a lot of contributors who have a lot of experience in SCAD. I'm a big fan of Headspace and Calm. There's also 10% Happier. So, you know, these online meditation apps can be really helpful. I went to Cal or Berkeley, so I'm a big fan of all of the resources that UC Berkeley has. And they have a whole center called the Great Good Science Center. And there's a Science of Happiness course you can take for free that kind of just talks through steps you can take to, exactly like it sounds, work toward kind of a greater happiness. They also have a Greater Good magazine where every day they have you focus on some other aspect of mental wellness. So if that strikes you as something that's interesting, particularly when a lot of us don't have a whole lot else to do, you can check out the Greater Good Science Center at Berkeley. So those are just some suggestions, resources out there for people.
Awesome. Those look great.
I love the Science of Happiness course.
Yeah, and it's free, so you know.
That was a COVID activity for me and my wife.
Oh, that's great.
We loved it.
That's awesome. And we'll post those links to those things too. We can post that below the video on when we put the recording up. Awesome. Those are really helpful. Thank you. You know, I think the post-SCAD, and then also there's a lot in people's lives. There's a lot in COVID year. There's a lot in, you know, the holidays. And I really like the point of reaching out now, thinking about doing that now before crisis hits. Couple questions, because we do have a few more minutes, that I wanted to ask some specific activities. Dr. Wells, I know you mentioned that, you know, we could go, I'm sure we could endlessly go through activities, but there have been several that I've heard a couple, you know, more than once. So these may be discussion or yes or no, and other people can jump into. Hot tubs, are hot tubs acceptable?
Hot tubs are acceptable.
Okay. Roller coasters.
Roller coasters are not acceptable.
Okay.
And, yes, and that we try not to be too dogmatic about it, because I always emphasize to the patients, probably like I said earlier, this is about quality of life and not about rules and limiting these things you enjoy and are meaningful for you, but within reason, adjusting some of those things and using your best judgment. And so, yes, again, for all the things that specific activities you're going to ask about, there's a little bit of a spectrum, but roller coasters is usually a hard stop.
That sounds good. My kids are very into roller coasters right now, so I'm fine with that answer.
Mm-hmm.
What about things like scuba diving, with the change in pressure?
Mm-hmm. So scuba diving is a tricky one, because there are different intensities of scuba diving, like different depths and temperature changes and pressures and things like that. That would be something you definitely wait to scuba dive a few months after any type of cardiac event to consider scuba diving. But in most instances, you would have at that point completed some type of cardiac rehab, increased your functional status, and were healthy enough to consider some type of slightly higher risk activity like that. And some cardiologists would even recommend doing some type of stress test, making sure your functional status is good on the treadmill before you did something with that high a degree of workload or intensity. And another thing to point out with the scuba diving specifically, or some of these other hobbies or sports, is you want to do it with a buddy as well. If you get into trouble scuba diving underwater, you could be in a little more trouble, you know, than other activities. But other things like swimming or hiking or something, you always want to have someone there with you, or even walking early after SCAD, because if you start having chest pain, you don't want to have these symptoms and you're alone.
Absolutely. How about something like skiing?
Skiing, so for snow skiing, again, so there's a slight bit of a pressure change and temperature change.
Right.
So for the lower intent, so we divide a lot of sports into competitive and recreational. We try to avoid competitive sports in general, and keeping that heart rate range lower. For most people who do competitive sports, they push themselves to a point where they're in that higher intensity range and they won't stop, and you could get yourself into trouble. But a recreational type of skiing is acceptable.
Awesome. Excellent. Thank you. I know some of those, again, to get specific, but they're ones, you know, I know we've heard a couple of times, so we wanted to make sure we address some of those. One last question before I get into this, wrap up with iSCAD registry with Dr. Grodzinsky, maybe, or if anybody else wants to add in. You know, we had somebody ask, you know, okay, so I'm learning all this about SCAD. You know, I've had my SCAD events, I'm learning all this about it. What's the best way to share information about SCAD with my doctor if I'm not lucky enough to come see, you know, one of you guys, you know, how do we do that without, you know, seeming like Dr. Google or, you know, being rude about that?
I think it's a great question. And I think that's something that we love to emphasize is self-advocacy, especially given sort of the emergence of more information about SCAD over the last few years. I think that if you have a nice relationship with your physician, be it cardiologist or your primary doctor or whomever your provider is, I think saying that, you know, you've had a chance to research this more rare condition, that you'd love to ask some questions. Hard to know what the baseline or background knowledge of the physician is, or experience in treating SCAD patients. You could say that you're involved within the SCAD Alliance, which is, you know, an advocacy and education organization. And gosh, one would hope that no doc would ever you know, be bashful about hearing that information from a patient.
Awesome. Thank you. And I know we have some information on our website too. Sometimes I've printed off things, you know, just as things to take. And it is really important too. We spent last month talking about advocacy and how important it is to speak up for yourself. So that's always good to hear and always reassuring to know, you know, that that's accepted and encouraged.
Absolutely.
Awesome. Thank you guys. I do want to touch just a couple minutes on the iSCAD registry. We've mentioned that a couple of times throughout here. The iSCAD registry is a multi-center independent registry. And Dr. Naderi, since you're on steering committee, I was hoping you could talk a little bit just about why is it important? How does somebody participate?
Yeah, so this is really, I think, Catherine Leon's brainchild with all of your support over the last, gosh, so many years. And a lot of blood, sweat, and tears went into launching this registry with a lot of people's help. So it's probably a little less than a year that we've launched with a growing amount of centers around the country. And the reason why we're so excited about this registry is because we're really trying to work on diversifying our geographic and socioeconomic diversity in the patients we're capturing within research about SCAD in order to more fully inform ourselves going forward on how to treat it and manage it. So basically, your physician fills out information on your history as they follow you longitudinally, and you fill out your personal history as you go along. We're growing the centers around the country. Dr. Wells and Dr. Grodzinsky's institutions or sites, as is mine. We're growing our the institutional involvement, but you're gonna have to, out there in the world, be patient with us as we grow centers and grow places that are nearer to your hometowns. You can get more information about where the centers are and how to contact them and how to go about getting enrolled in the registry through the SCAD Alliance webpage. There's an iSCAD link that gives you more information, but we're really, really excited. We just enrolled our 500th patient, I think a couple of weeks ago, and I know that sounds like a really small number, but for a relatively rare condition and in a short amount of time, we're really appreciative of all the patients who've donated their time and data. So hopefully we'll continue to grow from here. We'll see how things go.
Wonderful, thank you. I know that's something both as I have public health background and also as a patient, it's just really exciting to be able to have the opportunity for so much data over, you know, a large area. So we'll post that link. That's on our Facebook page, that to our website. And if you are at one of those centers, you can talk to your doctor about enrolling. And if your center is not listed there yet, hopefully we're coming soon. So I wanted to give one opportunity, just if any of the three of you had any additional things that you want to make sure we talked about today. Otherwise, I'm going to wrap up. I really, really appreciate you guys joining us today. A huge thank you to the panelists. This is always so informative and empowering as a patient to be able to go through you know, different topics with SCAD, and then also to see in action that, you know, nationwide collaboration. So just some logistics, we have recorded this. It's posted to our Facebook page. We'll also post it to our YouTube. And be sure to subscribe to our newsletter too at scadalliance.org. That way, that's where you can get information about the registry, upcoming webinars, and just other things going on. So thank you guys so much for joining us. We also want to say this is our last one for 2020. We want to give a big kind of year-end thank you for everybody's support throughout this year. So we're able to continue supporting research, and we're able to continue, programs like this. So thank you guys, and we will see you next year.
Happy holidays. Thank you.
Thank you. Great job
Happy
moderating.
holidays,
Rebecca.
everybody. Take care. Bye.
Bye.